The concept of steady state basically talks about the fact that when you administer a drug, you're hoping that you're going to get a consistent plasma level over time. In other words, your goal is to give a patient a drug, let it reach the appropriate level in the plasma, and stay there. That will be what we call a steady state, where the rate in is going to equal the rate out and the plasma level stays constant. It's also why steady state is referred to as the plateau principle. Because when you're administering a drug, if you're looking at a graph of that drug, how do you know that you've reached steady state? Easy. The curve will plateau. When the curve rises and then levels off, you have plateaued, therefore you have reached steady state in the plasma. It's really, really important to know that the time to steady state depends on one thing. It depends on the half-life of the drug. If you know half-life, you can predict time to steady state. And that is independent of any of the other variables that you might be given, like the size of the dose, how often that you're dosing. But we do have to assume that the drug is being eliminated by first-order kinetics. In other words, if you have one of those special cases of a zero-order kinetics drug, like phenytoin or ethanol or aspirin, then you really can't discuss effectively the concept of steady state because you can't discuss the concept of half-life. You don't have a consistent half-life, so your time to steady state will be variable for those drugs. That's not where we go with the test question. We go after those first-order kinetics drugs, those that follow the rule on time to steady state being dependent upon their half-life. In your margin is a note about time to steady state. But I'm going to discuss this a little bit differently from what that note actually shows you. The most important part of that note, by the way, is the time that it takes to reach clinical steady state. Clinical steady state, in fact, is reached in 4 to 5 half-lives. And clinical steady state is different from what we call mathematical steady state. It takes a lot longer to reach mathematical steady state. Clinically, when we get around 93 to 96% of the way there, that happens in 4 to 5 half-lives, we call that clinical steady state. It's almost like, hey, we're close enough. We'll take that. You're not at 100%, but you're very, very close. I do think you need to understand a couple of basic numbers here related to time to steady state. Think about it this way. If you start at 0 and your goal is to get to 100% of steady state, the way to remember the numbers is this. Each half-life, I get halfway to my goal. So I start at 0 on my way to 100. So after the first half-life, I get halfway to my goal. After one half-life, I'm 50% of the way to steady state. Now I'm at 50% on my way to 100%. In the second half-life, I get halfway to my goal. So what's halfway between 50 and 100? That's right, 75%. Now I'm at 75 on my way to 100. What's halfway between 75 and 100? 87.5%. So 3 half-lives in, I'm 87.5% of the way to steady state. And then once we get to 4 or 5 half-lives, we will call that clinical steady state. Some people are more familiar and more comfortable with the concept of elimination than they are with the concept of time to steady state. Let me just tell you that time to steady state and elimination, they really have the same values. Let's illustrate it this way. How much drug have you eliminated after one half-life? Of course, you've eliminated 50% of the drug. But by percentage, how much drug have you eliminated after 2 half-lives? It's taking half of it and then taking half of what's left. That's 75%. Again, you can use real numbers here. You can say I start with 100 milligrams. After one half-life, I'm down to 50 milligrams. After 2 half-lives, I'm down to 25 milligrams. I've lost 75% of the drug. And if I went to 3, after 3 half-lives, 87.5% of the drug has been eliminated. And by that same logic, how long clinically does it take to eliminate a drug? It takes 4 to 5 half-lives. So the time to steady state and the time for elimination really have the same values. If you're comfortable with one, You're actually comfortable with both, and that's good news. This graph is going to plot time versus plasma drug concentration, and it's here to show us the rise to steady state. The dose in this example is 100 micrograms per mil. I'm going to give that dose at time 0. When I give that dose, notice I go up to 100, and then I'm going to wait 1 half-life. The half-life for this drug in this example is 4 hours. 4 hours later, after my dose of 100 micrograms per mil, I'm down to 50 micrograms per mil. And then I'm going to dose again with another 100. So I go from 50 up to 150. I wait a half-life, I go to 75. I dose again with 100, I go to 175. And I continue to do that. I dose every half-life. And because I'm doing that, I'm going to have these peaks and troughs. Eventually, notice how the graph is going to level off. It's going to plateau. On the far right side of this graph, you can see that we have reached steady state. Again, that's why we call it the plateau principle. When the curve plateaus, you have reached clinical steady state. But since we're dealing with a dosing every 4 hours, and you have these peaks and troughs, once you reach steady state, you're going to have a CSS maximum at the peak and a CSS minimum at the trough. And you're going to fluctuate between those two numbers, which in this case is 100 to 200. Every time you dose, you're going to go up to 200, wait a half-life, you go down to 100. So there's our fluctuation. I could approximate a CSS average. In fact, if I were to give this drug by constant IV infusion, that's what that would look like. It would approximate that CSS average. But I'm dosing every 4 hours, so I have peaks and troughs. I've also added to this graph. At the very top, I've put in a minimum toxic concentration, and down at the bottom, a minimum effective concentration. Earlier, we talked about MEC. That's that plasma level where the drug first has its pharmacologic effect. Doesn't it make sense that at steady state, you want your CSS minimum to always be above the MEC? Even at the trough levels there, you want the drug to be working in the body. But if there's a minimum effective, surely there's a minimum toxic concentration as well. So at the peak, the CSS max, you want that value to always be below your minimum toxic concentration. That range from minimum toxic to minimum effective is called the therapeutic window. And as a physician, your goal should be to keep the drug levels in that therapeutic window. Some drugs, of course, are going to have very narrow therapeutic windows, and that influences how we dose them. We might, in fact, have to dose the drug more often just to keep the drug within that window. I'll tell you something else that people will do. People will sometimes forget to take their medication. Maybe they've actually been faithful taking it up to a point where they've reached clinical steady state, and they're at their trough level. They're at the CSS minimum. It's time to take the drug again, but they forget, or they've run out of their prescription. So the plasma levels start to drop, and eventually those plasma levels could go below the minimum effective concentration, and the drug won't be working anymore. But maybe more scary than that is that sometimes folks will miss their dose, and they'll remember some hours later, and instead of taking one as recommended, they will double up on their dose. And perhaps now they get very close or go above that minimum toxic concentration. So the drugs out there that you've heard about that have these more narrow therapeutic windows are the same ones where we caution, take as soon as you remember after you've missed the dose, but never double up. Never double up on those medications, because those are the ones that will put you over that minimum toxic concentration. This is a very important graph to illustrate the point that the size of your dose does not influence time to steady state. We see 5 different infusion rates on this graph, ranging from 1 up to 5 milligrams per minute. In fact, these are really 5 different maintenance doses. And that's the term that I want you to be very comfortable with. If your goal is to reach steady state, you're going to use a maintenance dose to do that. The word maintenance maintain. You're trying to maintain a steady state plasma level with a maintenance dose. But how do we know that a drug, when I'm infusing it in a case like this, how do I know that I've reached steady state? That's right, we remembered that we look for the plateau. Notice that whether it's 1, 2, 3, 4, or 5 milligrams per minute, every one of these curves levels off at the same time. They all plateau at the same time, so their time to steady state is the same. Time to steady state is independent of the size of your dose. What you'll notice, though, is that if I give a higher amount of drug, if I give 2 milligrams per minute instead of 1 milligram per minute, I will reach a higher level in the plasma. My steady state plasma concentration will be higher if I give more drug. That makes sense. The key is, but I don't reach that plasma level any faster if I give more drug. Keeping in mind, I have to focus on the plateau. That's where I'm going to call that steady state. That's where I know I've reached that steady state value. We also want to look at the effect of a loading dose. We know that it takes 4 to 5 half-lives to reach steady state. So if we're giving a drug by maintenance dose, we know that that's going to take a period of time. For some drugs with longer half-lives, that could be quite a long time. Some drugs have their half-lives being more than 12 hours. It's going to take probably a few days for certain examples to reach steady state. There are times, however, that we cannot wait that long. We might want to use what's called a loading dose. We do this to achieve plasma levels rapidly. You might think about emergency situations where you need to treat a patient very, very quickly. So we use loading doses. But most commonly, if we use a loading dose, it's just a single dose. It's just a one-time only dose. There's a note in the margin there, a clinical correlate, that reminds us that the loading dose equation can be used to calculate the amount of drug in the body at any time by knowing the volume of distribution and the plasma concentration. So we have a way to calculate this. We use it sparingly. Again, there's certain examples, like I mentioned with the emergency, where we might use the loading dose. In this graph, plotting time versus the plasma levels, we really see two different examples here. The example in the bottom, showing only a maintenance dose, is there to illustrate that it's going to take time in order to reach the minimum effective concentration. If we use the example of digoxin, a drug which has a half-life of almost 2 days, how long does it take digoxin to reach clinical steady state? Yeah, 4 to 5 half-lives means 8 to 10 days before this drug reaches those levels that we call clinical steady state. That's a long time to wait. Can you imagine? You're working in the ER, patient comes in, and it's your job to take care of this patient, and you recognize that they have a life-threatening arrhythmia. So you go up to that patient and you say, well, I have good news and bad news for you. The good news is we're going to use the drug digoxin. It's a very effective drug for your type of arrhythmia. But the bad news is I only know how to administer this drug by maintenance dose. So let's say if we only gave this person a maintenance dose of digoxin, look at how much time we're going to waste. In the first 2 days, we don't even reach the minimum effective concentration. The second 2 days, we barely reach it. For about 5 minutes, this guy's arrhythmia goes away, but then it comes back. Then finally, after day 6 and into day 8 and day 10, we're finally starting to control the arrhythmia. Of course, the big catch to that scenario is, did the patient live that long? This is a scenario where you're much better off using a loading dose, with the sole purpose of that loading dose being to achieve high plasma levels rapidly. We want to get enough of the drug in the body to be effective. So if I look at the far left of this graph, I give a loading dose there at time 0. My levels are large enough there to go above the minimum effective concentration. In fact, a typical rule on the loading dose amount is that a loading dose is often 2 times the maintenance dose. Your goal is to approximate the CSS max. In the example that we looked at a couple of slides back, when we were giving 100 micrograms per mil, that was our maintenance dose, so our loading dose would have been 200 micrograms per mil. That would have approximated our CSS max. A loading dose is only a one-time dose typically. So in this example, we give the loading dose, but we always follow up with a maintenance dose. And together, the levels of the loading dose plus the maintenance dose keep us above the minimum effective concentration. Some of you might be thinking that we have sort of cheated the rule about time to steady state. And we've really not, because time to steady state, when you're talking about that with your different types of doses, you're really talking about using only maintenance doses to get to steady state. Here we're actually combining a loading dose and a maintenance dose, and the sole purpose there is to have enough drug in the body to be effective. This slide is often pretty scary for folks because it involves all the different pharmacokinetic calculations. First thing I would tell you to sort of calm you down is to remind you there aren't going to be very many calculations on your exam in pharmacology. In fact, number one, the volume of distribution equation is probably the most likely equation to show up on step 1. That's the one we covered earlier. It's pretty simple. It's got 3 variables. Volume of distribution is dose divided by C0. And if you know 2 of those, you can pretty easily calculate the third. It's very unlikely that you're going to have to calculate half-life using this equation, 0.7 times VD divided by clearance. I wouldn't say to not learn the equation, though. I would know this equation, but what I would learn about it is what the relationship is between the variables. What's the relationship between half-life and clearance, for example? And you note that it's an inverse relationship. By the way, if you think about that, you already know that. You know that if renal clearance goes down, that half-life is going to go up. The drug will last longer in the body with lower clearance. Maybe harder is to remember that half-life and volume of distribution are directly proportional. If volume of distribution goes up, half-life goes up. Now, does that make sense based on what we discussed earlier? Sure it does. If volume of distribution goes up, that means the drug is leaving the plasma, being sequestered in the tissues. And since it's sequestered in the tissues, it's not going to the organs of elimination. Therefore, its half-life is going to be increased. So maybe learn the equation for the relationship among the variables more than for actually doing the calculation. Equation number 3, infusion rate, is actually included in the maintenance dose equation. So my preference is to really learn the maintenance dose equation, and you've already covered your bases there by learning the infusion rate. So let's look at number 4 and number 5, loading dose compared to maintenance dose. We've discussed why you would use those things. Maintenance dose is what you're going to do when you dose a patient day after day after day. Loading dose is the one-time dose that you'll do in more rare situations, again, perhaps in emergency situations. First thing is to compare the 2 equations. What do they have in common? Both involve a plasma concentration. CP for loading dose, CSS for maintenance dose. We use CP for loading dose because you're really just looking at a target level in the plasma. You're not trying to get to and maintain steady state like you are with a maintenance dose. But both equations use a plasma concentration. Both equations also have F. Remember, F is bioavailability. If we give the drug IV, that's great news for you because F is 1. That makes the math a little bit simpler. Now, let's focus on the differences. Do you notice how maintenance dose involves renal clearance and loading dose volume of distribution? I like to think about it this way. If I'm going to dose somebody day after day after day with a maintenance dose, I need to know renal function. I want to know clearance if I'm going to dose them day after day. If I'm going to give them a loading dose, however, a single dose, I'm not as concerned about clearance as I am where does the drug distribute. So volume of distribution is more important for me to include in my loading dose calculation. Make sure you pay attention to differences in the way we use those 2 variables. The maintenance dose equation also uses the variable tau. Now, tau is your dosing interval. That's going to be how often you give the drug. Is it once a day? Is it 4 times a day? That's what tau is in your maintenance dose. We don't need that variable in the loading dose. Once again, most often we're just going to give that as a single dose anyway. Now that we've finished chapter 1, Let's do a few practice questions to apply the concepts that we've covered. You can pause the video now, review the question. I'll come back and discuss in just a moment. In this question, we've got a 43-year-old man. It's really important to notice that he has a 7-year history of chronic renal disease. That's really the key. We notice that we have a patient with chronic renal disease. He started on the drug levofloxacin. And really what we want to know in this question is how is the dosing of this drug going to be different in a patient with chronic renal disease compared to an otherwise healthy patient. Of course, chronic renal disease is going to affect the clearance of the drug. Since clearance is not a part of the loading dose equation, you would expect the loading dose to be the same. Clearance is, however, a part of the maintenance dose equation. Since you're going to have reduced clearance, you're going to have a longer half-life of the drug, we need to lower the dose of his maintenance dose. The correct answer here is choice E. Same loading dose, but lower maintenance dose. Here's our second question. Once again, pause the video, review the question, then we'll review the strategies to solve. So here we've got a series of experiments that are performed to figure out how this drug is going to move within the body. A couple of clues in this question. Notice the statement that says when the extracellular concentration of the agent exceeds 10 millimolar, no further increase in the rate of uptake is observed. That's a very important component to this question. What that tells us is that when we go above 10 millimolar, we are saturating the system. Since the system has been saturated, that rules out one of our very common answer choices here, which is simple passive diffusion. Since it's saturated, this system involves a carrier. It leaves us really with two options, facilitated diffusion and active transport. The second part of this question addresses an inhibitor of sodium-potassium ATPase. When we stop ATP production, notice that it fails to inhibit the transport of this drug. That means the system in this case doesn't involve energy, so it's not active transport. That means you've decided it's saturable and it does not involve energy. Of course, the correct answer here, choice B, facilitated diffusion. Here's our next question. Once again, pause the video, review the question, and then we will discuss. So we've got a 13-year-old girl. She's brought to the emergency department by her father. It seems like this girl has taken a lot of the antihistamine diphenhydramine. We've got some information that shows the diphenhydramine concentrations measured hourly for 6 hours. The question wants to know how long after the first measurement is it going to take for the patient's plasma concentration to drop below 10. To solve this problem, the first thing that you do is determine the half-life of the drug. At 1 o'clock, the plasma concentration is 240 nanograms per mil. 4 hours later, at 5 o'clock, that level has been cut in half. We've gone from 240 down to 120. So we're going to presume that that is the half-life of this drug, which is 4 hours. You assume that because the drug is diphenhydramine. Diphenhydramine is not one of our zero-order kinetics drugs, so we're assuming that we're still dealing with first-order kinetics, and we can determine a consistent half-life. So given that the half-life of the drug is 4 hours, how long is it going to take to drop below 10 nanograms per mil? Calculate the number of half-lives that are going to be required to go below 10. The first half-life takes you from 240 down to 120. The second half-life, 120, goes down to 60. In the third half-life, we go from 60 down to 30, cut that in half. In the fourth half-life, we go from 30 down to 15, but we're still not below 10, so we have to go to a fifth half-life in order to go below 10. The fifth half-life takes us from 15 down to 7.5, so it's going to take us 5 half-lives to drop below 10 nanograms per mil. It's 5 half-lives times 4 hours per half-life. 5 times 4 is 20. Choice D is the correct answer.